We are Christina,
Oneida,
Alicia,
Colleen.
Welcome to 4NP's podcast.
This is a podcast by 4NPs. 4NPs, advanced practice nurses, students, and anyone interested in the medical arts.
That's the number 4 NPS podcast.
If you have a topic you'd like to see covered, please feel free to email us at 4npspodcast@gmail.com or reach out to us through our social media. Hey there, listeners, and welcome back to 4NP's podcast. This week, we're diving into a new type of episode. On occasion, we will be inviting guests that can teach us a little bit more about specific health topics. And in this week's episode, we invited Amber Tresca. She's a writer, she's a podcast host, and a patient with IBD. If you recall from nursing school, there are two main types of inflammatory bowel disease, also called IBD, ulcerative colitis and Crohn's disease. And both of these may involve overlapping symptoms, so there's a lot of gray area leading up to yet a third form of IBD as well. There was just so much to learn and glean from Amber's professional experience and her personal journey. We so appreciate Amber for taking the time to speak with us, and we're excited to share it with you. Have a listen.
Hey, Amber. So nice to meet you. Thanks for joining us today.
Hey, it's my pleasure. I'm so glad to meet all of you.
Us too. So anyway, we wanted to bring you here. We have a bunch of questions for you. So our podcast is by 4 nurse practitioners, and it's for nurse practitioners and students and anybody interested in medical arts. And we really wanted to talk to you because you're really an expert in IBD. So we wanted to hear your story and have you tell us a little bit about yourself.
Oh, well, thank you so much for calling me an expert. I will take that chart. So I am an inflammatory bowel disease patient. I was diagnosed when I was 16 years old with ulcerative colitis, and I'm 48 now, so I've been living with that for a while. In those days, it was the 80s, so there wasn't a lot of treatments available, and because IBD is a disease that goes in and out of remission, I never really went into remission. So about 10 years later, when I was 26, I had my very last colonoscopy, and things were very bad. My colon was falling apart. And so we decided to have surgery, which is a great treatment option for ulcerative colitis. So I had a subtotal colectomy with a J-pouch creation when I was 26. And it has given me exceptional quality of life. I've had 2 children since. And it has allowed me to have a career and have a life. And I work now as a medical writer and editor and have my own podcast focused on IBD and continue to do pretty well. Although sometimes people get into discussion whether or not you can cure ulcerative colitis with surgery. I fall into the camp that you cannot. Because things aren't perfect, but I do really well enough to be on this podcast with you all today.
That's amazing. So what is the process? Like, what were your symptoms when you were diagnosed?
So my symptoms started with pretty classic hallmark ulcerative colitis symptom, the big one, which is bloody diarrhea, constant, all of the time. And I was already a pretty small person and lost weight that I really couldn't afford to lose, probably more than 10 pounds, really, really rapidly. And I didn't have much sort of extra intestinal symptoms at the time, which is something that can happen with IBD because it does affect your whole body. But that was basically how it started. And then I went through a period where I was misdiagnosed. It was not very long. It was a few months, but it was long enough that my disease got very bad to the point where you're just going to the bathroom and it's nothing but blood. And so finally I got in to see a gastroenterologist and had a colonoscopy. And that was when he discovered that the inside of my colon looked, in my sigmoid colon in particular, looked very, very bad. And that was the source of all of the bleeding. And it, of course, it needed treatment. So I was hospitalized that time for more than a month. In those days, they did NPO. So I was given nothing to eat for a few weeks until some of the drugs started to kick in and I started to improve. And then finally enough to where I could be eating on my own and going to the bathroom less than 20 times a day. And then I was released at home to recover.
Wow.
Did they, so the misdiagnosis, where do you think that came out of? Like, what did they suggest that you had or was wrong with you?
This is a good one. You're going to have a laugh. They called it intestinal flu. I don't know what that is.
Okay.
Intestinal
Right.
To this day, what happened was I ended up in the emergency room one morning because, what else do you do, right? So we went to the emergency room and the emergency physician there never did a rectal exam, really didn't, I don't even remember him physically examining me, to be honest. And they sent me home with some antibiotics. And sometimes antibiotics are used to treat IBD, so that did help a little bit, but it's not something that's a long-term thing. So when I saw my pediatrician, she got me off of that and we started to try to figure out what it was. But it was really the fact that I needed to get in to see a gastroenterologist that was the biggest thing so that they could make that diagnosis.
So I have a question because I feel like IBD, irritable bowel disorder, and irritable bowel disease can kind of be used interchangeably. Like some people I notice when I see patients in primary care talk about like constipation versus diarrhea as a form, and that can be a form of irritable bowel disorder. Do you come across that?
So, inflammatory bowel disease and irritable bowel syndrome. So that's where we get caught up there with the IBD, IBS.
Right.
Because IBD is a disease. There's actually, there's pathology. You're going to find something when you go into the digestive system. And irritable bowel syndrome, which is a syndrome, you're not going to find anything. You're going to do a colonoscopy and probably not find any pathology there. But it is still a very debilitating condition. And further complicating the whole thing is that people who live with IBD can also live with IBS. And the symptoms overlap, as you know. So people think about the diarrhea and the constipation, which constipation can also be a problem with the other form of inflammatory bowel disease, Crohn's disease. That can be a problem for people with Crohn's disease. So it can be really tricky to tease out the two. But the thing that I always go back to is that inflammatory bowel disease is a disease. You're going to find something that's causing the actual inflammation. And with irritable bowel syndrome, you're not going to find that. They used to call it a functional disorder. I think now they've moved beyond that and are calling it different things now because it's not so functional. But you're not going to find inflammation that's causing the symptoms for irritable bowel syndrome.
So for like a new person having like symptoms like, they're bleeding per their rectum, and what can you tell, like if you're going to a nurse practitioner, you're going to a doctor and then you're following up with a nurse practitioner, what would you want them to know about your disease in order to better treat you? Right.
It's interesting because I do see a nurse practitioner on a regular basis who I love. We used to be on kiss hello terms, not during the pandemic, but basically, right. We get along really well, and I love having a nurse practitioner on my team. And I think a nurse practitioner can help a lot with education, simply because, you all tend to have more time to spend with patients and can maybe help them find the resources that they need. Because IBD affects every part of your body and every part of your life, and you don't know what's going to happen. One week you can be fine. The next week you can be needing very specific resources. So when nurse practitioners can be more educated about the disease and also about the resources that are available to patients, and I'm talking just support for your mental health, or maybe you need some help finding health insurance or getting something covered. I think these are things that nurse practitioners can help with. And I also think some of the more challenging parts of IBD, that you go in to see your physician and sometimes it feels like it's all about how many bowel movements do you have? And yet you've got all these other problems too. You've got your mental health needs to be addressed. You may have problems with sexual function that need to be addressed. And I think these are the type of things that nurse practitioners can really help their patients with, that go beyond sort of how many bowel movements are you have, and here's the medication that you're going to prescribe. So that's what I would look for. And, when I sit down with my nurse practitioner, we really do sit like in 2 chairs across from one another and kind of have a little chat. And I love that part about having her on my team.
That's awesome. Is she a general, like a family health nurse practitioner, or is she a specialist in GI?
She's an FMP and she specializes in GI.
She does. Okay.
Yeah.
And then one thing you mentioned before, you said the extra intestinal symptoms. Can you talk a little bit about what are some of, so just to back up a little bit. So when we're in school to become NPs, excuse me, this is a very broad topic. So, we touch on GI and we definitely go into, IBS versus IBD, and you're kind of just, we're not really exposed to these patients. So when we're taught out of a textbook, and I can picture the table. You guys can probably picture this too. There's a table that, has ulcerative colitis and Crohn's and the differences between those. And then they teach, irritable bowel, and they teach inflammatory bowel, and it's very broad, and it's very hard to wrap your head around when you're just learning out of a textbook, which is where a lot of the nurse practitioners who would listen to our program would be. They're, unless that's your specialty, you're touching on it really. And so what we hope to do with our podcast is to really, like, one of the things that really, first of all, I love your podcast. It's awesome. And it's very educational. And I think that it helps us as nurse practitioners to get the broad picture of what does this person look like to us, so that when I see that patient, not just a list of symptoms or, what is this person going to look like to me? So if you could just talk about some of the extra intestinal symptoms, like some of the other things that I might hear a patient describe if they were coming in for the first time, or if they had a history of this. And what am I looking out for?
Right. Yeah. And some of the patients that I'm sure you've heard on my show, they have very long diagnosis journeys in some cases. And I think sometimes that comes about because their disease is not necessarily all about having, a lot of diarrhea every day. So it may not be something that their medical team is thinking of right away. And also, IBD is a family disease, but it's not really a family disease. Like, there is inheritability there, but it's not like it gets passed down that everyone who has the genes for IBD is going to go on to develop IBD. So most patients, in fact, don't have a family history of the disease. Otherwise that would give you a clue right away, right? But if they don't know anybody that has it in their family, then, you're still coming up empty trying to look to what's causing all of these symptoms. But people with IBD can also have problems with their eyes. It can range from, very serious eye disease to just dry eye. Sometimes they have problems with their skin. So you're talking things like eczema, rashes, things like that. Also, there are a couple of more serious skin conditions that can occur with IBD. And also people with IBD tend to have issues not only with the diarrhea, but also with the constipation. So, these things, and the abdominal pain, but not everybody has abdominal pain. So you see where I'm coming from here, that this is really it's really challenging, So it's like, we can tell you like what all of the signs and symptoms are, because it is all stemming from that inflammatory process. So that inflammatory process is somewhere going on in your body. It tends to focus on somewhere in the digestive system, but then it's also got tendrils going out affecting your skin, your eyes, your joints, all the other parts of your body. And one of the things that a lot of IBD patients will point to as their main symptom, the thing that's causing them a lot of problem too, is the fatigue. that you just have so much trouble functioning. So, if someone doesn't come in with, copious diarrhea or bloody diarrhea, but then they have all these other things going on, and sometimes it might be difficult to put them all together. Well, why do you have episcleritis? Like, why is that happening with your eyes? And it could be that it's because of that inflammatory process that's going on with your IBD. So it really is challenging. I feel for anybody that's that's going through the diagnosis, but at the same time, nobody should go through a diagnostic process that takes years. Like that shouldn't happen. And some of the things that get looked for right away that don't involve a colonoscopy might just be, blood work. There's a test called fecal calprotectin that you can look at, things like that to just, at least get started until you can get people in for an endoscopy or colonoscopy and see what's going on inside of their digestive system.
How do you feel that the diagnostic process has changed since you were diagnosed to now? And the medications must be much better now. The labs, you said the fecal calprotectin, did they do that on you when you were first diagnosed? How's it changed?
Yeah, the fecal calprotectin is a newer thing, so that wasn't around when I was diagnosed. And I was fortunate in my diagnosis journey that I had very strong advocates in my parents that were pushing. And, as 16-year-old girl with bloody diarrhea, that's pretty clear, what it is. It wasn't anything, they didn't find anything in my stool. There was no C. diff or anything like that, no parasites or something, off the wall like that. So I needed to see a gastroenterologist and get that checked out. So it was a pretty clear path. For people whose symptoms are not so very clear, it becomes more difficult. Yeah, there was no fecal calprotectin. There were 2 treatments available to me, and at the time when I was diagnosed, and that was sulfasalazine and prednisone. And those are still used to this day, although we know a lot more about prednisone now. We knew then that it caused really significant side effects, things that you don't want. And now we say, steroids are bad, so we don't want people on them for a really long period of time because they can affect your bones and, gives you all sorts of problems. I was on such high doses that, my cheeks were out because that's what happens. And, you get acne and this and that. But that was what was available to us at the time. So in the 30 years since, there have been several other drugs developed. There's been the 5 ASA drugs and biologics. There's a spectrum of biologics that are available now. And now that's turning a little bit. We're sort of calling that the biologic age, right? And now there's other new medications with different mechanisms of action, some of which I'm still trying to understand myself how these things work. But there's another class that's called JAK inhibitors. That's there's at least one on the market right now. There's a lot of other things in the pipeline. So I saw a tweet from a physician, an IBD doctor, the other day, and Twitter is a really great place for learning about IBD, by the way. That seems to be where all of the IBD-focused practitioners hang out. And they said, IBD is a complicated disease. Okay, we all know that. And it used to be simple to treat. That was only because there was only a few options available. And now there's so many options. It can be, and it was bonkers to me when I needed to go on a biologic that we sat down and talked about which one. It was like what they were asking me, Amber, what do you want to do? And it was like, oh, well, this is nice. I like this, having choices. So it is an entirely new ball game. And every so often, when I go to one of the medical meetings that's IBD focused, there will always be somebody that has a slide that has the pipeline in it. And it's always like this bonkers, you can't even read it slide because there's so much coming up. So it's really hopeful. A lot of IBD treatments they're not effective for everyone, which is why people go from treatment to treatment. So it would be great to have something that works, that has better efficacy. But when you find the right drug for the right person, People tend to do really well now. They don't get as sick as they used to back before we had, the biologics and the JAK inhibitors. So I've really seen treatment come a long way. I think it still has a long way to go, but it's very clear that people are working on it and are passionate about it, and that's what gives me hope.
That's amazing. It's got to be like life-changing, everything, like all the new treatments, and like just when you're diagnosed, like just it's got to be like amazing for the patient, just the person to be,
I think it's overwhelming too. It's like, I think that's one of the biggest things, and something, because I was diagnosed so long ago, my doctor gave me a book, like literally, no websites, no, nothing like that. Right. It was just like, but he was wonderful. And so he gave me this book, and we sat there, I sat there in my hospital bed and read it. And then I would go to the library and look through medical journals and things like that to try to get information. And now there's so much more information and there's so much more support. I don't think that necessarily dulls that impact when you're hit with that diagnosis. Most people have never heard of it before until they're diagnosed with it. And then to understand that it's a chronic condition, you are going to have to take care of yourself in a different way from your peers. It is not going to go away, but it can be managed well with the medications that we have now. And I do know several people who they hit on the right medication for them, and they do really, really well, And then there's also some discussion, some controversy now about if people get into a deep remission, can they actually de-escalate treatment, and stop using their medications and then maybe ramp that back up again if their symptoms take an uptick, So that's an incredible thing. So it has been really great to watch, and I have friends that are doing so very well, and I'm so grateful for that, because my 10 years of living with active disease was horrible. It was not a great time. So having new treatments and new ways of being diagnosed quicker, it's been great to see that.
It's awesome.
Amber, I was just wondering, because it's similar symptoms between Crohn's and IBD, right? And obviously there's a different track that Crohn's takes, but is it hard for providers to, differentiate? Obviously the colonoscopy will be the defining way to diagnose, but I just wanted to know is it hard to differentiate a lot of times? Have you found?
Yes, so it can be. And there is a third form of IBD, just to make your life more interesting, called indeterminate colitis. And that is when someone has disease that's primarily in their colon, but it doesn't really look like ulcerative colitis, but it doesn't really look like Crohn's disease. And so they're in that indeterminate colitis category, which is not a small amount of people. The biggest problem, I think, with that is indeterminate colitis doesn't have any medications that are FDA approved for it. So they tend to treat it like ulcerative colitis. But the two main forms that most people that have an IBD have, ulcerative colitis and Crohn's disease. Crohn's disease, like I said before, these diseases affect your entire body. But when we're talking about the digestive system, Crohn's disease can be anywhere from your mouth all the way down to your anus. So if you're finding disease in your small intestine, that's going to be Crohn's disease. But then there's a form of Crohn's disease that's called Crohn's colitis, and that is primarily focused on the large intestine. So that's where you're going to find the disease there. So I think that's where it gets tricky. But when you're looking at the inflammation in ulcerative colitis, it starts at the end of your colon. So it starts in the sigmoid and moves up. So it spreads. And that's a key point that nobody ever told me. They were like, oh, it's in your sigmoid colon. I'm like, okay, that's where it is. No, it moves up, and it can eventually take over your whole intestine, which is called pancolitis, which is what I eventually ended up with because my disease was not well controlled. So that's what goes on with inflammation and ulcerative colitis. In Crohn's disease, it can be patchy. So you can have different patches of inflammation in different places, and then you have healthy tissue that's in between. So that, sometimes it's really clear that that's what's going on. With Crohn's disease, there also tends to be other things going on, like there can be perianal disease. So people might have fistulas or abscesses in their perianal area, and that's more common with Crohn's disease. And the thing about it too is that IBD is such a spectrum that we have to have these buckets. We have to have these Crohn's disease, ulcerative colitis buckets because that's how drugs get approved. But a person could be anywhere along that spectrum, and it's theorized that there could be hundreds of different forms of IBD. We just put them into these two categories for now. I would love to see that teased out and get more specific for people. But for now, that's what we have. And the inflammation tends to be the biggest thing. Where the disease is located is another part of it. And then also the extraintestinal symptoms that are going on, like the perianal disease, can be an indication that it's Crohn's disease and not ulcerative colitis. So those are a few of the things that are different between the two different forms.
And Amber, is this categorized as like an autoimmune? I mean, is it considered autoimmune?
This is another fun question because when I was diagnosed, we didn't really have these terms for it, and then I'm trying to remember sort of exactly around when it changed, but people started calling it an autoimmune disease, and it was like, oh, this is an autoimmune disease. But now the IBDologists, so the people that are very specialized in IBD, are calling it an immune-mediated condition and not an autoimmune condition. So immune-mediated is a really broad term. There's things that fall under it. But I think the tide is turning on this, that we're getting away from autoimmune and we're getting into that immune-mediated category. So this is like such a very difficult concept. And I've interviewed a couple of different IBDologists about it to try to understand it myself. But I think we're getting away from that autoimmune, although that I think that's probably going to stick around for a while, that people are going to continue to refer to it that way until maybe we sort of get some guidelines or something that come out and state that it's not autoimmune, but that it's immune mediated.
It's interesting. I mean, you're starting to hear a lot more about the immune system being regulated by the gut and the importance of all of it with immunity. So it'll be interesting. I haven't heard that term before, immune mediated. I've never heard that term before, so I'm going to have to do some research myself. But it's interesting. I wasn't sure how they categorize that. So
yeah, and you're going to find a lot of things on the internet, and probably some of the things that I wrote that I need to go back and revisit, that say that autoimmune, because that was the term that we had, and now it's moving along, and because they're understanding more, right? They're finding all of the genes and discovering that the microbiome is involved, and they're testing fecal microbiota transplants for IBD to see what happens there. So like, as we are understanding more and more about these diseases, which is fantastic, because I feel like when I was diagnosed, we didn't know anything, so now, because that's the way we're going to find the ways to treat it, right? And that's the way that we're going to find the right drug for the right person at the right time, instead of just like, try this and see what happens, is doing all of this research and understanding that inflammatory process and exactly where it's coming from.
It's so interesting.
And you had touched on in the beginning, like the mental health aspect of it. Like what, as you go in and you see your practitioners, what do you wish that they had told you when you were first being diagnosed? Like do you suggest somebody go and see a mental health provider? Like, what do you suggest?
It's funny because when I have interviewed IBDologists about this topic, they also have a difference of opinion about what to do here. So in some cases, they feel, it's been their experience, that maybe referring someone to a mental health provider right away might not be the best way to go, that maybe you want to let things breathe a little bit before you give them a referral. But I do think that at some point, yes, there does need to be a referral. I think the diagnosis in and of itself, I think, is a reason for a referral. And I think it's also helpful for patients to understand that this doesn't mean that you need to be in therapy for the rest of your life, but dealing with the diagnosis at first, it might be helpful to speak to someone. And then with the other things that can crop up as you go along through your disease, it puts a strain on your relationships. So if you are dating, it's going to put difficulties there. If you're married, it's going to put difficulties there. If you are a child, there's going to be difficulties within the family, what your parents are dealing with, your siblings. It really doesn't matter where you are in your life. It's going to affect your mental health. So I think there definitely needs to be a conversation about it. Not everyone is going to want therapy or anything like that, but it should be a conversation. When I was diagnosed, they sent me, when I was an inpatient, they sent me a social worker a couple of times, but that was really kind of it. There really wasn't any more than that. And in those days too, and it's this misconception still persists to this day, that it was thought that you developed IBD because you were this, you were this stress ball and you had all these problems and that's why you developed IBD, which is not true. But that doesn't mean that you don't need some help, because right. The disease itself and, how it affects you and how it affects your body and your finances and, your career and all of these things, people can need help through it. So even just being asked the question about your mental health, I think is huge, because a lot of people don't even get asked about that and certainly don't get referred. And there is a subspecialty of psychologists that work in gastroenterology. So, referring someone, they're few and far between, and they're the most amazing human beings I've ever met. So if you can find one like that to treat you, that's fantastic. But also I think a mental health professional that deals with chronic illness and understands chronic illness can be really helpful, because it really is its own thing. And I don't like to say you can't understand it unless you live with it, because I think that you can, but it would be really helpful to have someone that understands chronic illness on your side and helping you with your mental health when you're diagnosed with an IBD.
Absolutely.
Yeah. There's a lot of nurse practitioners out there in mental health, and that's a really good point to make for them, if any of them are listening. So that's another great education piece out of all of this. Thank you.
And I think that, your website, your podcast, everything is so helpful. And just the age of social media has got to have, been so helpful for the IBD community. Just having that outlet and being able to just explore, like when you were first diagnosed, I mean, you said you had to go to the library, Most kids nowadays, they don't even know what a library is. So I think it's awesome. Like, what you're doing is just phenomenal. It's got to be like life-changing.
Yeah, the social media, it's so interesting because on the one hand, I could not go to a search engine and search for something when I was first diagnosed. That's, not great. But going into the search engine and searching for it is also not great, because you might come up with things that scare you. I interviewed someone recently who had this idea that Crohn's disease was fatal, and it's not. So, you can tend to get the wrong idea, which is why I think nurse practitioners are so important and can really frame that conversation and hit on those, few things in the beginning that, you can do well. We're going to treat this. don't go and ask the search engine about it, because what you're going to find, and people are going to do it anyway, what you're going to find is scary. Social media can also be scary. And this is something that I say a lot, in particular with J pouches, which is what the surgical procedures that I had, where I have a rectum that's created out of my terminal ileum because I don't have a colon anymore. If you go into social media and you go into the groups where people who live with a J pouch are, who are you going to find there? You're not going to find the people that are doing awesome and out there. You know, I mean, I have friends with J pouches. They're bodybuilders. One of my friends, she had twins. You know, I mean, they're living their life. They're not, you know, needing to go and find help and support. So there can be a little bit of a skew there. But on the other hand, I think it does prepare you and help you think about some of the things that maybe you should be looking for. For instance, people with J pouches can develop a condition that's called pouchitis, where you end up basically having ulcerative colitis symptoms all over again, which is not fun. But it's very treatable in most cases. But I see people all the time who are like, gosh, they're experiencing the symptoms. They have a fever, they have bloody diarrhea, they don't know what's going on. And it's like, well, you have pouchitis. So you need to go and get that treated, but nobody ever told them. But at least when they come into a forum where there's a lot of people who are living with the condition can go, oh, this is what the deal is. Call your doctor. You know, here's what's probably going to happen when you get there, you know, and come back and let us know what happens, type of a thing. So that can be really wonderful as well. And I've made some of the most amazing connections. I mean, I always say my podcast is very selfish. Like, I'm glad that practitioners can listen and learn. Like, that was never my intent. I love a good conversation. I like talking, and I like meeting other people with IBD. So I've met some of the most amazing human beings, like instantly friends, you know, when you meet other people with IBD, because you have this shorthand already. There's all of this stuff that you don't have to explain. Like, that person already knows. So I think something that nurse practitioners can also do is help facilitate those connections. If you have a couple of people with IBD in your practice, you know, maybe one of them is willing to serve as a mentor for newly diagnosed people, things like that. And that's happened to me a couple of times in my journey, that I've had physicians that have hooked me up with another patient. So meeting someone else with a condition, because in your regular life, you're probably not going to. I mean, I do all the time, because I can never get away from talking about people's, you know, bowel habits. So you know, I'll meet people with IBD all the time in my regular life, but that doesn't happen to other patients. So facilitating those connections can be really, really helpful. And then online advocates. I forget who I was talking to on my show about it, but we were saying how that it must be really difficult to sort of send this advocate a message and ask them a question about something you're dealing with your IBD. That's such a vulnerable thing to do, a position to be in. But online advocates who are public about their disease and try to bring information and resources and support to people that live with IBD are always so welcoming. So that's totally something that patients can do, is message other patients and make those connections and form those bonds. And then maybe also get some answers to their question, or even just a little support. You know, if you're going through a colonoscopy or something like that, I think you know, posting about it and talking to other people about it, you know, they'll be right there behind you telling you, you got this and we're here for you, and let us know how it goes when you get home.
That's great.
Amber, I had another question. I don't know if you found diet-specific, nutrition that's helpful, that's made it worse, or if it's not really made an impact at all.
Yeah, I always say that diet is the new religion. So it's like, if you ever want to hear a whole lot of opinions, you can just start talking about diet as it connects to IBD. What I was told in the beginning was that diet doesn't matter, but we know now that it absolutely does. But in what way? That's, I think, the biggest question. And from my going to meetings and hearing IBDologists speak, they tend to give their patients a couple of different recommendations when it comes to diet, one of them being the Mediterranean. And there's a few other diets out there that might be recommended that patients might try. The one thing I think that's really important and where nurse practitioners can help is making sure that patients get hooked up with a registered dietitian, because I think trying to navigate all this diet and all of the research and what you should be trying is really difficult for someone to do on their own unless they've maybe had some training or done a whole lot of research. And patients with IBD will tend to, when they're not feeling well, they'll eat the things that go over well and avoid the things that don't go over well, which sometimes means eating bread and pasta and simple carbohydrates and things like that, and sort of not eating the fruits and vegetables. But there's ways to incorporate all of these things when you're not feeling well, and the registered dietitians know how to do that, and they'll give you recipes and help you out and all of that. So diet totally matters. The research is, I feel like it's still in its infancy. There's been some studies that have come out recently comparing to diets, but I don't know that we can really take that and apply it to every single patient, because you also have cultural influences with diet as well. So that needs to be accounted for. So patients need to pay attention to their diet. I think that when they go to see their team should be asking them what they're eating and what kind of help that they need, because you might not know that your patient is only, eating like 4 or 5 foods, and that's not going to, help them get back to a diverse, microbiome, and then also giving them the energy that they need to get through their day. For myself personally, I've never really found, I've lived with a J-pouch for so long now, it's been 20 years. I always say that, like, I still eat a lot of salad, but maybe just not 2 salads in a day. So, there's a little bit of trial and error that goes on there. But I think for sure, patients need help with this. They need some guidance. And even if it's just someone else that they can, work through the trial and error with is going to be so helpful for them.
That's great information. I also want to find out, I know a lot of the medications that IBD patients are on can be expensive. Is there any a website or any services that you can recommend to people with IBD that would help them, with that high cost?
Yeah, it's really awful. Yeah. So the first thing that I will often tell patients, it's going to depend on which drug that you're receiving, is to go in and find out who makes that drug. Especially with the biologics, which are prohibitively expensive, they often have patient assistance programs. And that's usually for patients that have commercial insurance. So, but it's going to depend on the manufacturer. So find out who makes your drug and then contact that company, find out what support that they can offer you. There are lots of nonprofits that offer support. There's too many to even go through, but when you start to look, you can find lists of the nonprofits that can offer help for patients paying for drugs. The other thing that I will say is that this is something that we work on in activism. So if you want to get involved, if you're having trouble paying for your drugs, this is something that we need to deal with. This is something that we need better laws around, to get in contact with your local representatives and then your congressional leaders and let them know, tell them your story. You don't have to be incredibly well versed on insurance and how that all works. I know I certainly am not, other than the fact that I know that I like having insurance. Not having it when you have IBD is bad. Yeah. So contact them, tell them your story, because we need help. Patients need their medication. I hear too often about that a patient will be prescribed a drug, but then they can't receive that drug because of the cost, or they can't receive that drug because their insurance says, no, we want you to take this lower cost thing first. Right. which is something that happened to me as well, and something that I tell my congressional representatives when before we were not able to go to DC. I used to go to DC several times a year and tell my story and advocate for better care for all patients with chronic illness. This doesn't just help people with IBD because biologics are used for many, many different diseases. So find out who makes your drug, see what help you can get there, talk to your team. I think a lot of patients might not feel comfortable telling their team that they can't afford their medications, but that's something that nurse practitioners can absolutely help with. And then get involved in activism because we definitely need more voices. And for anyone that doesn't know how to do that, I'm always happy to help. I'm pretty easily reachable, hopefully. And I've actually done several episodes on my show about how to get involved with activism that people can use for a template to build their own activism journey. So that's what I would suggest.
Hey, Amber, can you just tell us and our audience how to get in touch with you? I know that there's a lot of different places that you're writing and a lot of websites and your podcast, and I want to hear about all of it. So let's share that with everybody.
Oh, you want to hear about all of it?
I do. I want to hear all of it.
Nobody ever wants to hear all of it. Yay! So I am all over social media as About IBD. I'm all over social media as About IBD. I'm easily findable that way. My podcast is also called About IBD. You can find that in pretty much every major podcast platform. And you're already listening to this in one, so just open it up. Look for About IBD or look for Amber Tresca and you will find me. I am a writer for Very Well Health. So verywellhealth.com. You can find lots of IBD focused information there, some of which I've written, some of which I haven't. And you can also get in touch with me through IBD Moms. And IBD Moms is a nonprofit that I founded with my friend Brooke Abbott, who is also known as the Crazy Creole Mommy. And we founded that for moms who are touched by IBD. So moms who have IBD and moms who are caregivers for their kids with IBD. And we're all over social media as IBD Moms. So I encourage everyone who is an IBD patient, or for your listeners who are practitioners who are interested in learning more about IBD, to follow us on social media and get in contact. And hopefully we're great resources. And, I think it's pretty obvious that it's my passion. Educating patients is my passion. And so I'm willing to help people do that in any way that I can.
You're amazing. I just want to let you know that. I just think that, for just all of your different outlets that people can communicate with you and just learn about you and all of your, I work at a GI practice, and I'm totally going to start recommending you, because I think it's so important, because this disease can be debilitating, and just having that outlet can, there of course are a lot of different medications, and it's definitely, possible to live a normal life, but just for those people going through the acute process, and it's just starting, and they just think that it's going to be debilitating for the rest of their life, just knowing that there's hope out there and having that information is amazing. So thank you.
Oh, thank you. I love this idea of your show. I wish you great success. And if there's any way I can ever help, I will certainly do so, because teaching NPs more about IBD is just fantastic. You guys telling me the little bit of education that you get on it when it's such a complicated condition. And of course you can't, unless you're GI focused, of course you can't learn everything about every condition. But teaching your colleagues about this is really wonderful. So thank you so much for having me on. And I really am looking forward to hearing what you guys do next.
Thanks so much.
Thank you so much.
Thanks, Amber. Thank you for listening. If you like what you're hearing, please subscribe to us and give us 5 stars.
If you have any ideas or comments, please message us at 4npspodcast@gmail.com.
Please follow us on Instagram, Facebook, and Twitter at 4NPs Podcast. That's the number 4NPS Podcast. Subscribe to us wherever you get your podcast and go to our website at 4npspodcast.com for episode transcripts, resources, and more information about us.
Thanks again for listening, and make sure you tune in to our next episode where we'll be having a discussion with Trish, a nurse practitioner who specializes in gastroenterology. See you then.
The information in this podcast is for educational purposes only and should not be used in substitute for professional care by a medical provider. The information in this podcast does not represent medical or other professional advice or services. The thoughts and opinions presented on the 4NP's podcast are of the hosts and guests and do not represent those of their employers.